Welcome to the AETCM, the Emergency Medicine channel. Today we will be discussing about the national guidelines for the snake bite.
Okay.
So as per the national guidelines...
Snake bite management.
Okay. So as per the guidelines of 2017, what are the indications to give ASV will be first dealing. So the indications to give ASV are if there is fang marks and fast spreading local swelling, and also if there is tender local lymphadenopathy, it is one indication. Then any hemostatic abnormalities, that is when we are doing a 20-minute whole blood clotting time or deranged PT, that is an indication. Then if the INR is more than 1.2, PT is more than 4 to 5 seconds and platelet count less than 1 lakh. Then any neurotoxic signs such as ptosis and ophthalmoplegia, hypertension or shock or arrhythmias in the patient coming with complaints of oliguria with red color urine and elevated creatine kinase and hyperkalemia, which may go into rhabdomyolysis, and in these cases ASV is indicated. Along with this, if signs and symptoms of envenomation without evidence of laboratory test, we can also administer full dose of ASV without any delay. And if the patient is presenting to our hospital with history of bite which is known or unknown, and if there is spontaneous abnormal bleeding beyond 20 minutes from the time of bite, then we need not wait for the reading of 20 minutes whole blood clotting time. We can initially itself administer ASV. Now coming to the ASV, about the ASV.
What are the problems of 20 minutes whole blood clotting time?
20 minutes whole blood clotting time, when we are measuring, it should be a sun-drained clean glass bottle. If it is a detergent washed, then it can affect the clotting time and blood may not clot. Okay. So it should be a sun-dried clean bottle.
It's okay.
Then initially...
one, you have to wait for 20 minutes.
20 minutes.
Second thing is, only up to 80% of your bleeding proteins, they are deficient. More than 80% of the bleeding proteins are deficient. Then only this test will become positive. That is a negative problem of this test. That's why we are more depending on INR, PT-INR. But according to WHO, many other hospitals, they don't have this INR.
Point of care INR is not
so
available.
they can use it.
Whole blood clotting time. Then coming to the ASV, ASV is the only specific antidote to the snake venom, and in India we use a polyvalent anti-snake venom, and it will be only neutralizing our big four. That is, the big four contains the cobra, crate, Russell's viper and the saw-scaled viper.
Amno spit viper.
It is not included in the ASV.
Snake, sea snake.
No, nothing. Only these big four is involved. But even then, the guidelines say that if the venom is closely related, then it might work, and that is known as paraspecific neutralization. Okay. So that can be done. Then about the storage and shell life, there are two forms. It can be lyophilized form or the liquid form. Lyophilized form is shell life is about 5 years, and it should be stored at a temperature of 25 degrees Celsius. In liquid form, it should be stored in cold chain, that is 2 to 8 degrees Celsius. So if suppose our ASV's expiry date is over, even if we don't have an alternate choice and it is indicated, then we can give. Okay. That is what the guidelines say. Then coming to how to administer ASV, there is no need of giving a test dose in ASV, and ASV is only given via IV. It cannot be given IM or subcutaneous. And then according to the
previous guidelines used to tell that IM can be given if you have a long transportation, but now because if you don't get an IV line and you require the patient to transport in a distant place, IM can be tried, but current guidelines says it cannot be given.
Only IV is preferred. And then according to the guideline, it is told that give prophylactic epinephrine, that is 0.25 mg of 0.1% solution. Sub-Q injection can be given, and there are some exceptions to that. If the patient is hypertensive, if the patient is a known case of cardiac issues, and if the current BP is more than 140/90, then we need not give. Otherwise, prophylactically epinephrine can be given sub-Q. Then coming to the administration part, initially each vial we will be reconstituting in 10 ml of sterile water or distilled water or saline. So it will come up to 100 ml. So initially always we are giving 10 vials. So that is reconstituted in 100 ml. And then we will be administrating it as IV. So while we are mixing, it has to be...
How much time you can take when you are giving IV?
First dose should be within 30 minutes according to the guideline.
One vial should be given over.
We are giving 10 vials, sir. Initial starting
10 vials should be given
over 30 minutes.
30
minutes.
Okay.
So when we are mixing it, it should be done by swirling movement and not by vigorous shaking. And after mixing it,
since it is a protein, if you shake it like that, what will happen? Froth will form. Half of the dose will be will be lost.
And if the reconstituted solution is opaque, then it should not be used. Its quality has been destroyed, so it shouldn't be given. And then while we are giving, we have to observe the patient every 5 minutes for the first 30 minutes and then every 15 minutes for the next 2 hours, so that we will be ruling out any adverse effects of giving ASV. So that has to be taken care. Now coming to the ASV dose as such. ASV dose we will be giving in 2 formats, that is for neuroparalytic snakebite and vascular toxic snakebite. If it is a neuroparalytic snakebite, that is the cobra and crate, then we will be giving 10 vials stat as infusion over 30 minutes and followed by second dose of 10 vials after 1 hour if there is no improvement. So initially we will be giving 10 vials in 100 ml over 30 minutes. 1 hour we will be observing the patient. If the patient has no improvement, next second dose will come. That is also 10 vials.
Okay.
So that is the dose. Now,
so whatever you have decided to be given in the first 1 or 2 hours. Otherwise, what will happen? If you delay, some doctors give ASV 1 or 2 vials, TID dose and all. It will be given. It is given in some hospitals. So what will happen if you give like that? Complete detox,
the venom will be not neutralized completely because it depends on the how much gram of venom has been injected.
That is okay. If you delay the treatment, what will happen? What is this proteins of a snakebite? Is a protein that will go and attach to your cell and it will produce damage. Once it is attached to your cells, that area of that attachment, it is gone. This whatever we are giving, that is also going to attach that area of attachment. So again, once it is producing damage, you cannot do anything. So better to give whatever you want to give in the initial hours, like 10 vial, 20 vial, maximum is 20 vial in this.
Yes. So in neuroparalytic we will follow this. If it is a vascular toxic, then there are 2 regimens. Either we can go with low dose infusion regimen or high dose intermittent bolus regimen. So if we are going ahead with the low dose, in case of Russell's viper, initially we will be giving 10 vials, and if it is saw scaled viper, they are telling to give as 6 vials. That will be giving over 30 minutes, followed by 2 vials every 6th hourly as infusion in 100 ml of normal saline till clotting time normalizes or for 3 days, whichever is earlier. So initial thing is 10 vials or 6 vials, and then every 6th hourly we will be giving 2 vials each.
Why these 6 hours are taken by them?
Because the coagulation factors takes 6 hours.
So we have to check the coagulation time. If the coagulation time is still high, you have to again re-infuse. Only problem is by the 6 hours or 18 hours, patient will become bad. So only this guideline, it will be very difficult to accept in an area where there are large number of snake bites. There they have to decide whatever dose they want to give. It has to be infused in first hours only. This is given only because you can only get an idea whether the patient is improved or not only by 6 hours minimum.
Then coming to the high dose intermittent bolus therapy, we will be giving 10 vials of ASV over 30 minutes infusion and followed that 6 vials every 6th hourly as bolus therapy. Here we don't have infusion. We will be giving bolus, high dose bolus will be given. These are the doses for neuroparalytic and vascular toxic. And then coming to pediatric or pregnant females, the dose is same. There is no alteration in the dose. And the upper limits, like how much vials total can be given. In cases of crate and cobra, that is the neurotoxic, they suggest that 40 vials is the maximum dose. We need not go more than that. And in case of Russell's viper, it is 20. And saw-scaled viper, it is 10 is what the new guidelines tells. So basically, if it is a neurotoxic, 40 is the maximum. Russell's viper, it is 20, and the saw-scaled is 10 is still telling. And then which all time we can give this ASV. If the patient is presenting very late after the snake bite, if at all patient survives and presents late, if there is evidence of coagulopathy, then we can give ASV is what the guideline tells. Then coming to the adverse effects of ASV, within 10 to 180 minutes, patient can develop early anaphylaxis. Symptoms of itching, nausea, vomiting, angioedema, hypotension, shock, bronchospasm all can come. Then within 1 to 2 hours, patient can also develop pyrogenic features. And in the later period, patient can develop serum sickness, that is from 1 to 12 days, where patient can present with fever, arthralgia, myalgia and lymphadenopathy. And in case of anaphylaxis, if the patient develops, we have to immediately stop the ASV infusion. And if the patient is anaphylactic, then we have to start on our adrenaline. Normal protocol of 0.5 mg IM will be given. And if patient is not improving, every 5 minutes we will be repeating the dose. And if it is a refractory anaphylaxis, then you have to start on infusion, epinephrine infusion. And along with this, the guidelines also suggest that giving anti-H1 blockers, that is chlorpheniramine maleate, can be given. Dose will be 10 mg in adult and 0.2 mg per kg in children. Along with this, hydrocortisone also can be given, 2 mg per kg, but it will be not effective for the initial hours, but it can be given. And once the patient has recovered, ASV should be restarted. ASV shouldn't be stopped. It has to be restarted, and you will have to start very slowly for the initial 10 to 15 minutes and observe the patient. Then coming to the response to the treatment, we will be looking whether the patient is having overall general improvement, that is if there was any headache or pain abdomen, whether it has started to come down. Coagulation factors, we have to look whether it is getting normalized. We have to look for any hypertension or cardiotoxicity features, and whether the neurotoxicity features are also coming down. All these features would come down within 30 minutes to 1 hour. That is why we are telling repeat the second dose after 1 hour. Then recurrence of systemic envenomation happens when there is continuous absorption of venom from the depot at the site of bite due to improved blood flow after correction of shock, after the elimination of initial dose of ASV from the body and redistribution of venom from tissues into vascular space. Then coming to neurotoxins and ASV. Along with this ASV, if we are having a neurotoxicity, we can also administer atropine and neostigmine, because here in cobra or the crate, what happens is acetylcholinesterase will be inhibited. So the acetylcholinesterase will be more and acetylcholine will not be working. So here we will give neostigmine so that it will inhibit the acetylcholinesterase and increase acetylcholine. So what we give will be the dose 1.5 mg will be given. And since we are giving neostigmine, patient can develop bradycardia and increased secretions. So to counteract that, we'll also give atropine 0.6 mg.
Okay.
So initially here we have to give atropine 0.6 mg followed by neostigmine 1.5 mg, and repeat doses of neostigmine 0.5 mg with atropine every 30 minutes for 5 doses has to be given. And later we have to taper the dose at 1 hour, 2 hour, 6 hour and 12 hour. Majority of patients will improve within the first doses, and observe the patient closely for 1 hour to determine if the neostigmine is effective. After 30 minutes, any improvement should be visible by improvement in ptosis. We will be looking whether ptosis is improving, and if ptosis is improving, this is effective. So for all the neurotoxic, along with the ASV, we have to give neostigmine and atropine. Now, even if after 3 doses it is not improving, then we should eliminate the possibility of cobra, and we should think that the snake might be crate. Right. So in that case, if we are suspecting crate, we will be going ahead with the injection calcium gluconate, and the dose will be 10 ml IV. We have to give slowly over 5 to 10 minutes, and then every 6th hourly we have to continue this calcium gluconate till the patient recovers, till the neurotoxicity recovers. That can be given up to 5 to 7 days.
Cobra it is neostigmine, other one
crate it is calcium gluconate. So these are the main differences which has come in the new guidelines.
Calcium gluconate was there first itself, but it has come in WHO guidelines now. That's all. It was there in other guidelines, but WHO guideline they are not included.
And then the other new thing is that if the patient is developing decreased output, not able to maintain urine output and going into the rhabdomyolysis kidney injury stage, then they are also telling of forced alkaline diuresis. It can be given within first 24 hours. If it is delayed, then there is no role, but within 24 hours, if you are giving, it is good. And then that forced alkaline diuresis has a systematic protocol. So initially we will give furosemide 40 mg IV stat, followed by we have to give normal saline 500 ml with 20 ml of sodium bicarbonate over 20 minutes. After 20 minutes, we will change it into ringer lactate 500 ml plus 20 ml of sodium bicarbonate. Then it has to be given in 5% dextrose 500 ml plus 10 ml of potassium chloride over 90 minutes. And at the last, we will be giving mannitol 150 ml over 20 minutes. So this is basically a 2-hour 30 minutes protocol. So this protocol can be given for the patient, and we will see whether the patient develops adequate urine. So that also has been included, forced alkaline diuresis. And even with that, if the patient is not improving, the patient is developing uremic toxicity, that is encephalopathy, pericarditis, fluid overload, potassium more than 7, systemic acidosis, and creat more than 4 with a urea more than 130, then those patients has to be taken for dialysis.
Spit viper, what is the treatment?
Spit viper, ASV won't affect actually.
So what is the treatment for that? For them, dialysis. Dialysis is the only treatment available. Cytosorb therapy, it's not given in the guideline.
As such,
Cytosorb therapy can be tried,
and
especially in viper bites, spit viper bites.
And then other than these, adjuvants are also there, where you can give your FFP cryoprecipitate, and prophylactic antibiotics also are being suggested, that if this patient is developing cellulitis, then you have to give your injection amoxicillin plus clavulanic acid 1.2 gram IV thrice daily for 7 days, and following that it has to be given as orally for next 3 to 7 days. So basically 14 days of regimen is what been suggested. And if amoxiclav is not available, alternatively ceftriaxone 1 gram BD can also be given. So that is the prophylactic antibiotics. These are the main things.